Right now, 20% of the American population is taking a psychiatric medication. That's what this circle is, and really where I believe it should be is right here, at about 5%. So what is going on that we have potentially 20 times as many psychiatric medications being prescribed than really need to? That's what we're going to be discussing in today's video. So why do I believe these medications are so overprescribed? Well, it's because I actually think that they're dangerous to a lot of people in the long run. Now, this may sound crazy, and I'm a psychiatrist, and if you've ever come across psychiatrists before, they've probably told you that these drugs are safe and effective, just take them forever, you'll be fine. It's simply not true. And so here's the problem with these medications. A lot of them, people will get used to them over time, and they'll need higher and higher doses. So that's the first issue. The second issue is that I actually think they can make some people worse in the long run. And so when we're talking about something like tardive dysphoria, which is when someone takes an antidepressant for a long period of time, they eventually end up feeling flat. They have a lot of low energy. Sometimes they can even feel agitated. They feel very numbed out as well. And then when you give them additional medications, none of them work. And then the doctors tell them that they have treatment-resistant depression. They blame it on the underlying condition. That's not the case. Sometimes that condition is induced by the drug, and we never really know exactly when that's going to happen. Other reasons are, once you get on these drugs, they can be nearly impossible for some people to stop. They can be incredibly painful, and if you come off them too quickly, they can cause brain damage for some people. It's called protracted withdrawal. And then also, a lot of these risks, and also a lot of these drugs have risks which really ought to be avoided. For instance, post-SSRI sexual dysfunction, this permanent sexual dysfunction that people can develop from taking these antidepressant medications. And right now, the APA says that these antidepressants should be a first-line treatment option for anxiety and depression, and that's just not safe at all. So there's a lot of reasons why people should be really wary of getting on these medications, especially for long-term use. Now, you might be thinking to yourself, Josef, where is all of this coming from? Because I've been told that these drugs are safe and effective. Well, what your doctors usually leave out when they say safe and effective is that they're safe and effective for the 3 months these drugs were studied for. That's right. When these drugs come onto market, there's a double-blind period for 3 months where there's an active drug and there's a placebo. And yes, usually the active drug will beat out the placebo over those 3 months, but sometimes not even by a lot. And if you look at the averages, at least for the antidepressant clinical trials, it was like 3 points on a 50-point scale. It can be really minimal on average. That's not saying that some people are going to have better responses than others, but on average, it is small. The other thing that they do in these studies is after that 3-month period, they continue studying the drug for up to a year. It's called an open label extension, but it's just people on the drugs. So you can't assess whether it's effective anymore because, like I said, the placebo group falls away. And then that follow-up year, they're just looking for rare safety problems. So really, if we're going to talk about the data that tells us that these drugs are effective, it goes on for 3 months. It doesn't go on for several years, like most people who take these medications. And so it doesn't really match up. But then you might be saying, well, if it doesn't really match up like this, why did my doctor put me on these drugs? Why do they keep on telling me it's safe and effective? Why does everyone seem to be getting put on these drugs? And that's what we're going to talk about now, because there is corruption going on in psychiatry at the moment. There is full-on manipulation that has convinced lots of doctors out there that these drugs are super safe and they can give them to everyone. And also a lot of people just in the media and on TikTok and different famous people out there, they're all wading in saying that these drugs need to be given out more liberally and there needs to be more access to them. Not true. I'm talking by a factor of 20, let's reduce them. And I want to talk to you a little bit about how that happens. So let's discuss. So we live in a world where what we hear about medications has been massively influenced. That might sound like, yep, I'm wearing a tin hat right now, but I want to walk you through all of the ways that public opinion about these drugs has been totally skewed to the point that we are killing people with these drugs and we are disabling them with these drugs and we are putting people who never should have been put on them in the first place on them. And it really happens because there's massive commercial vested interests in making these drugs seem a lot safer than they are. A lot of this is driven by the pharmaceutical industry, but some of it's also driven by like professional bodies, like the political group that represent all the psychiatrists in the US. And so I want us to go through how this is how all of this happens. So the first thing that like drug companies and such will try and manipulate is doctors, and they go after academic psychiatrists who are running the leading institutions, Harvard, Yale, Princeton, UCSF, all of these places. Now, if you are an academic in one of those institutions, one of the best things that you could do for career advancement is to publish and get an international reputation. That's how you kind of get to the top of the greasy pole. And if you partner with a drug company, they give you clinical trials to run at your institution, and then they publish papers with you, and that really helps pad your CV, and they fly you around the place so you get this international reputation, and it helps you ascend in your career. So you end up getting a lot of these very drug-friendly doctors leading institutions, and then sharing their very pro-drug views with the doctors that they're training. So I'm going to put over here, so what the drug companies do for these guys is they do career advancement, and that leads to bias. And so the friendlier these professors are at these major institutions to the drug companies, the more clinical trials they get, the more status they get, the better that their careers go. But the sad part about this is they end up sharing all of this stuff with the doctors that they're training, and then it makes them worse doctors. Okay, the next thing here is research. So I used to work in the drug companies, and once you get a drug on the market, you never talk about anything negative to do with the drug again. From your perspective, it's in the label, FDA knows about it, but the drug marketing doesn't end there. A big portion of like drug marketing is to keep on publishing stuff about your drugs in the journal, and they only will focus on the positive things. And so no doctors are ever going to, pick up an article, written by a drug company that's going to focus on a side effect. It's only going to focus on the benefits of the drug, or maybe some new indication that the drug can be used in. And so the next thing that you're going to see here is only focusing on positives. So if you're like a doctor and you just pick up an article, you're gonna start thinking that these drugs are a lot better than they are, because you only ever read positive things. Now, down here in the media, drug companies, they'll have PR firms, and they will look for opportunities to speak about how much of a big impact their drug is having, but also things kind of tangentially to that as well. They're going to try and increase the market size out there. They're going to say, depression, anxiety, it's out of control, there's limited access to these medications. They're going to try and whip kind of the public up into this state of believing that, these drugs are underused and we need to have more of them. That's their bias, that's their agenda. Now, some groups like that run the psychiatric associations as well and organize around the doctors, they do this as well because they want their sort of prestige to come up. They want it to seem like the problems that they're treating are really important. And so you get a lot of like media stories saying that, that the drugs are really needed and people are underdiagnosed. And so that happens through PR. Okay. Over on this side, what we're going to talk about is what happens when negative things come up about the drugs and what they do. So, for instance, let's say a doctor publishes something negative about the drug. Well, they can sue them, or they can threaten to sue them, or they can destroy their reputations. Two really well-known cases about this was Nancy Oliveri, when she was one of these academics working on a drug for thalassemia, which is a blood illness. She started saying that there were problems with the drugs and she wanted to talk about it. And then when she did publicly, they absolutely destroyed her in the media. They destroyed her professional reputation, and they threatened to sue her. The same thing happened with David Healy when he was accepted to be a professor at the University of Toronto, but he was talking about antidepressants and suicide risk. Drug companies, they used their influence to essentially get that rescinded. Both of these are really well documented online. And so you end up in this situation where if anyone sort of speaks out against it, they face, not only like career repercussions, but they just get like attacked in the media because these drug companies will publish articles about them saying they're wrong, and and their colleagues, their other psychiatric colleagues will be like, oh, I don't want to be associated with this guy who's in the middle of this like shitstorm right now. And so they kind of get ostracized as well. And so that's what they do. They do, I guess we'll call them ad hominem attacks. And so this sort of creates this environment of fear about talking out about the risks. And so a lot of people are like, I'm not going to talk about that because I want to sleep well at night. Okay. As for research now, okay, so we're coming over here to like the research side of things. They simply don't publish negative research. Now, Eric Turner brought this up about 10 years ago when he looked in the FDA's files because you could do one of these things called a, what's the name for it? A Freedom of Information Act. And they did a Freedom of Information Act to access the clinical trial study reports. And then they compared the number of studies the drug companies had done to get the drugs on the market to what was actually published in the public literature. You know, not just that was in the FDA got over here that was never published, what was in the public literature. And they found that drug companies, they simply do not publish their failed studies. That's crazy. Now, there's been some changes there, and I think that we're making some headway getting them to do that. But this is a recent change. And so for a long time, if there was negative research about a side effect of the drugs not published, and so no one sees it. And again, that totally skews public perception of these because you're only ever hearing positive things about this. Now, down here in the media section, obviously, like you have this PR firm here that works for the drug companies. And so if there's like a big scandal about the drug, like the drug's making someone suicidal, their PR firm can go out there and sort of run interference and just sort of wave it away. But one of the best things that you could do as a drug company is make it seem like it's not you running the interference, that it's actually someone else. And so I've seen this happen in two ways. So the first way that I saw this happen was actually when I was in the drug companies. So when a negative story would come out, maybe someone pretty senior in the company, they would call up like academics who were in the clinical trials with them or who they have a relationship with. And they'd get on the phone and they'd say, hey, did you see this really negative article from, Mark Horowitz and Joanna Moncrieff? Would you mind publishing like a response to that? I can have my guys write it up and we'll put you on the authorship line. This thing is just terrible and, we need to put them in their place. And so they'll kind of like write this thing. They'll send it out to these like independent academics out there who are drug friendly, who are more than willing to comply because remember, career advancement if you play nice with the drug companies. And then they publish this thing. So you have like David Healy or Joe Moncrieff or Mark, publishing like, hey, we should be concerned or worried about these things. And then all of a sudden some guy from like Harvard or Yale is just like, just so you know, we completely disagree with this. We think that these doctors are, foolish. And so that was one way that I saw it happening a lot. Really sneaky. The other thing that they do is they'll support unbiased like centers out there who have an agenda to shut this down. So let's say there's something really negative coming in about drugs. They might reach out to their person at like Depression Bipolar Alliance or some of these like patient-run groups. There's these patient groups out there who are kind of pro-drug. They get a lot of funding from drug companies, and then they'll get them to complain, and then it'll look like it's coming from this grassroots patient organization who's really against it. And they also do this other thing where they support places like the Science Media Center. Doesn't that sound neutral and unbiased? So the Science Media Center is this like a media watchdog that reaches out to journalists and rebuts things that they don't agree with. And it seems like it's just this independent group that wants to that really cares about getting, combating misinformation out there. But when you look at the funding sources, it's just completely filled with like the drug companies. So there's a clear conflict of interest there. And so we're going to say they secretly fund, and I'm going to put quote unquote independent groups to respond. Okay. Anyway, so let's shrink this up and let's talk about the effect that this has. So the effect that this has is that doctors out there believe the drugs are more effective than they are. They never hear about risks, but they're also afraid to talk about them as well, because they see what happens to people, okay? They see what happens to people who don't agree with this. They get their reputations destroyed, and it's super stressful. So that's one piece that you have to be aware of. There's been this complete manipulation of information about these drugs, and that's why it's like way bigger. They're way overused. Now, I want to talk about something else, because there's another really big reason for why these drugs are overprescribed, and that's actually just the American healthcare system, or it might be the healthcare system where you are, whether you're in Australia or the UK or somewhere in Europe. A lot of our hospital chains are kind of run by private equity groups, and the funding actually for the care, it's funded through like insurance. And so the way the insurance system works is you're incentivized for seeing more people in less time. And so I've done the math on this before, and when you look at the coding, like if you saw one patient for an hour and you build insurance as compared to seeing 4 people in an hour, you make like 40% less. So you're nearly making half as much if you choose to see the one person. So obviously, if you're a private equity hospital chain, you're going to encourage your doctors to see people really quickly. If you're a private practitioner, you've got this perverse incentive where you just want to churn through people. And so what this means is, when someone comes in and they're having a relationship problem or a work problem, are you really going to sit down and get to know them at the root cause and maybe do some motivational interviewing and maybe set them up with some people who can help them? You're not, because you can't do that in a 15-minute visit. Really, what you can only do in a 15-minute visit is prescribe a medication. And in the follow-up, all you can do is like, do you want to go higher? Do you want to hold it the same? Or do you want to go lower? That's not the care that you'd want for anyone that you loved. If you actually, you would actually want someone to sit with them, understand their problem, and fix it at the root cause. And so, relationship problems, work problems, help them in that way, get them set up with the right people. You might also have people coming into you, like kids with ADHD, and their diet is terrible. Do you really want to put them on a stimulant, or do you want to have some hard conversations about what they're eating around their home? Talk to them about what the family dynamic is. Talk to them about how the parents might be able to read to them more, how they can move things around. All of that stuff is just getting skipped, and it's just getting replaced with drugs, because there's incentives in the way we deliver healthcare that make doctors want to see patients really quickly. So let's talk about the next thing. So the next issue is that in the US, and this is why I'm so excited if Bobby Kennedy passes the Senate confirmation hearing this Wednesday, that's in 2 days. One of the things I would be really excited for is he's going to ban pharmaceutical advertising, because sometimes people just come into their doctor's office and they just go, I have ADHD or I have depression and I need a drug. And because we have this system where people get seen in 15-minute visits, the doctor's like, oh yeah, sure, it's FDA approved, let's just go for it. And again, it's just like another way I think the drug companies are just really harming people, because that's not the kind of care you would want for anyone that you really love. Okay? So let's move on now. Let's go back to this thing up here. You'll see that there's a 5% in there. So who should be getting these drugs? How do you know who should be getting these drugs? And there's a way to think about it. And let's just kind of draw this out. So I've drawn this out. This is a simplification, but it's a great way to think about mental health, okay? So we've got 2 pathways for people who develop mental health problems. So life stress, right? So if you are having mental health problems because of life stress, and the main ones are you having relationship problems, you don't like the work that you're in, or you're grieving, this is a no drug territory. Or if you take drugs, you take them for like 2 weeks, and then you get off them, because in the long run, it's just a negative. It's going to make you worse in the long run. And so if you are having psychiatric problems because of life stresses, do not take drugs, okay? So you'd be surprised that this is not obvious to a lot of people. A lot of doctors in these 15-minute visits, they'll just like put people on these medications because they moved towns and they got lonely, or they went through like a divorce. They won't set them up with the therapists and the people to help them and support them and like meet with them more frequently. They don't do any of that. They put them on drugs. That's a big no-no. Don't do that. So this is just avoid it. But there's actually a lot of people out there who have problems that come to them out of the blue. This could be things like severe anxiety, severe depression. It could be things like schizophrenia. It could be things like bipolar. We're talking serious mental illness. And we don't want to throw the baby out with the bathwater here. We don't want to say, drugs are bad and no one should get them. But there should be a system before you put people on these drugs. And so let's talk about that here. Okay, so out of the blue. First thing that everyone should get before they get put on these drugs is a comprehensive medical assessment. And I'm not talking just like something from your PCP. Personally, I recommend that they get a functional medicine assessment because you can pick up a lot of things that the PCP doesn't look at. Sometimes there's nutritional deficits, problems with like your B vitamins, problems with different vitamins. And if you fix them, the people feel a lot better. Sometimes there can be like gut colonization by things like Clostridia or yeast that can make people just feel terrible. Sometimes you can have problems with your zinc and your copper levels. And if you fix those, the people feel a lot better. But there can also be larger things like sleep apnea. If you're having sleeping problems and you have sleep apnea, if you get that resolved, everything goes away. If you're having thyroid problems, if you get that resolved, everything goes away. And so a full medical assessment, like a real one from someone who knows what they're doing, find like a functional medicine doctor, someone who has a tilt towards psychiatry, and get them to look at those things, because fix it at the root cause, right? Don't just mask it with symptoms. And so the first thing everyone needs to do is get a good medical assessment to make sure nothing is being missed, no hormonal things or sleep apnea or some of these functional medicine things. So this could be things like mold as well, or metal toxicity. You really need someone to have a close look here, because if you miss it, the chances are you feel bad for a long period of time and you'll be on drugs. The next thing that you can do is actually, let's go here first. Let's go to diet. Some people out there who have severe depression or bipolar or schizophrenia, for reasons that I'm not aware of, they respond to removing gluten from their diet and the ketogenic diet. And this is just mind-blowing. We've had people come off drugs after decades of use. Personally, I know many of these people who are on these drugs for like 2 decades. You get rid of gluten, they get better. Lauren Kennedy West from Living with Schizophrenia had been on antipsychotics for schizoaffective for 10 years. She did a ketogenic diet. She's off meds for the first time ever. There's a lot of research here coming out of places like Stanford, and there's huge interest. Go to the Metabolic Mind website. If you can treat your mental illness with a dietary change, just think about the trajectory that puts your life on. It's either you're on an antipsychotic med and you're dealing with the side effects, the weight gain, the cognitive problems from it, your potential is just like capped here because you're pushing through a drug every day. But if you get on this diet, maybe you don't need to be on the drugs and you return to a normal life. Now, this is not going to happen for everyone, but everyone should try it. I would try it. I would encourage it to my family and my children. Working on your diet could be the best thing that you could do to get through that. Now, let's say, for instance, maybe you have a psychotic illness and you've tried these other things and they don't work. There's a lot of therapies out there. There's things like CBT for psychosis. Maybe you have a level of psychosis that doesn't need to be medicated. That's a hard decision to make. You need to figure that out with your family and your doctor, but you may make the decision you just don't want to be on it. You might have OCD and you might need to do exposure response prevention therapy. So there's some targeted therapies out there that directly address those issues and may help you avoid drugs. Now, if you've tried these things like medical treatment, diet, doing targeted therapies, and you're still struggling a lot, by all means, take the medications, get informed consent about them, and then use them. That's what this 5% is about. This 5% here should be for people who've had a proper medical evaluation, who've done dietary changes, and who have done proper psychiatric therapies, psychotherapeutic therapies, and then were informed about the drugs. That's who should be getting them. That's where there is benefit for these drugs. That's where it outweighs the risks. Everyone else, I think they're kind of playing with fire, because even if the drugs are working now, they may not work forever. And that's what I see every day in my practice. People who are just like, I was on this SSRI for 20 years and now I just feel terrible and I need to come off. And maybe they've had 10 years of feeling kind of bad anyway. And it just would have been better if they were never on the drugs or they had found other things. So that's why I think that these drugs are used by a factor of 20 more than they should be. And this is who really should be getting these drugs. I hope this video was helpful. Let me know what you think about it in the comments below.